Hi everybody, and welcome to our module on placental complications. Let's start by talking about placental abruption, which is also called abruptio placentae. In this condition, the placenta detaches prior to delivery of the baby. Initially, the placenta implants normally, but then there is partial or complete separation early before the baby has been delivered. It's very high yield to know that this is caused by blood loss from the maternal vessels, not the fetal vessels. In this condition, there is usually rupture of maternal vessels in the decidua basalis, and this leads to separation of the placenta. To understand this better, let's draw a picture. So in a normal pregnancy, you have the myometrial layer of the uterus followed by a decidualized layer of the uterus, and the chorionic villi grow into that decidualized layer, and that's how the placenta attaches. What's happening in this situation is that maternal vessels are delivering blood into the decidualized layer to fill those chorionic villi. If one of those maternal vessels breaks or ruptures, then blood will leak along this plane between the myometrium and the decidualized layer and cause it to separate from the myometrium. That will lead to placental detachment, and that's how placental abruption occurs. Now, there are also fetal vessels bringing blood into the chorionic villi, but those are usually not the source of the problem. It's usually the maternal blood vessels that rupture and cause the decidual layer to separate from the myometrium, and that leads to placental detachment. And I've summarized these points here. Blood separates the decidua from the uterus. This leads to a loss of gas and nutrient exchange, and this is a life-threatening condition for the mother and the fetus. The clinical presentation of placental abruption usually occurs in the third trimester. The classic presentation is the abrupt onset of painful vaginal bleeding. Now, in actual practice, a posterior placenta may abrupt with minimal or no bleeding, but in a board question, it's usually going to be the abrupt onset of painful vaginal bleeding. There may also be abdominal or back pain. The uterus will begin to contract and the woman can feel this, and it's often diagnosed clinically. Ultrasound is not reliable, and because it's life-threatening, the baby needs to be delivered immediately. Complications of placental abruption include maternal shock. The mother can go into shock from massive blood loss. In addition, the loss of blood flow to the placenta can cause fetal distress, and the baby can even die in utero. And disseminated intravascular coagulation, or DIC, which I talk about in the hematology videos, is a classic complication of placental abruption. Another potential complication is cortical necrosis. I talk about this in more detail in the renal video on tubulointerstitial disorders. In this condition, there is ischemic necrosis of the renal cortex. Recall that the cortex is the outer portion of the kidneys, and that's what holds all your glomeruli. This is a rare cause of acute renal failure. It often occurs in the setting of ischemia and DIC, and it can lead to permanent renal failure, and a patient can end up on dialysis. And this is often associated with placental abruption. So the clinical presentation will be a woman with abruption of her placenta who develops acute renal failure, anuria, hematuria, which may be gross hematuria, and flank pain. That woman likely has cortical necrosis, which is a rare cause of acute renal failure and can lead to permanent renal failure. Risk factors for placental abruption are shown on this slide. So a woman who's had one abruption is at risk for more. There's something about her that sets her up for that condition. Women who have hypertension or preeclampsia can have abnormal uterine vessels. In fact, the pathophysiology of preeclampsia involves abnormally formed spiral vessels, so it's obvious that that could potentially lead to a placental abruption. Smoking and cocaine can disrupt the blood supply to the placenta, and that can lead to abruption. If a woman's uterus is abnormal, she's at risk for abruption. So if she has a bicornuate uterus, which is an abnormally shaped uterus, or if she's had a prior C-section and there's scar tissue in her uterus, then she's at increased risk for abruption. And then finally, any type of trauma, including a motor vehicle accident, can potentially lead to a placental abruption. Next, let's talk about placenta previa. The word previa means going before. So this refers to a placenta that is before the baby, meaning it's attached to the lower uterus over or close to the cervical os. This is a picture of what it looks like on the screen here, and you can see that this is going to be a problem at delivery because in order for the baby to get into the birth canal, it needs to go through the placenta, which could cut off its blood supply. Placenta previa may cause painless bleeding during pregnancy. The idea here is that with the placenta over the cervical os, some blood can be lost into the vaginal canal. It may lead to a preterm birth. Women sometimes go into labor early, and it often requires a C-section delivery to safely get the baby out. The etiology of placenta previa is not well understood, but one of the theories is that this happens when other parts of the uterus are abnormal, so the placenta cannot attach there. And if you know that, then it's easier to remember the risk factors. So first of all, a woman who's had one placenta previa has already shown herself to be the type of person whose placenta likes to attach over the cervical os. And then women who've had a prior C-section or multiple prior pregnancies may have other parts of their uterus that are not entirely normal. from the prior C-section or the prior pregnancies, and therefore the cervical os ends up being the best spot for the placenta to attach. Next, let's talk about a velamentous umbilical cord. To understand this better, let's imagine that we've got a little baby inside the womb. Under normal circumstances, the umbilical cord of the baby travels from the umbilicus and inserts directly into the placenta. In a velamentous cord, it's a little bit different. You still have the umbilical cord traveling from the umbilicus of the baby, but instead of going straight to the placenta over here, it inserts into the membranes, and then the fetal vessels travel exposed through the membranes to the placenta. So the problem here is that Wharton's jelly is only present in the umbilical cord, which stretches from here to the membranes. There's no Wharton's jelly protecting the fetal vessels as they travel with the membranes, and that leaves them prone to rupture. So I've summarized these points on this slide. A normal umbilical cord inserts into the center of the placenta. In a velamentous cord, the cord inserts into the fetal membranes. It attaches to the chorion, and at that point, the fetal vessels travel with the membranes to the placenta. These vessels are exposed, and what you want to remember for step 1 of your boards is that they have no protection from Wharton's jelly. Therefore, there's a risk of rupture or bleeding. And here's a picture of a velamentous umbilical cord. So you can see that the cord inserts right here, and then the fetal blood vessels travel through the membranes. They are not protected by Wharton's jelly. They then go to the placenta down here at the bottom. And in many cases, a velamentous cord is identified prenatally by ultrasound, and often a woman is offered a cesarean section as soon as the baby is viable to limit the risk that these vessels might rupture and harm the baby. Oftentimes, a velamentous cord occurs together with a condition called vasa previa. So as I told you before, the word previa means before. So in a vasa previa, the blood vessels come before the baby. This is a picture of what it looks like shown on the screen here. You can see that the umbilical cord inserts into the membranes like we talked about for a velamentous cord, but now those exposed blood vessels run across the cervical os. So if this baby is delivered vaginally, the baby will rupture the fetal blood vessels. If this isn't detected ahead of time, then the rupture of membranes at birth often leads to bleeding. Usually it is detected ahead of time and a C-section delivery is performed because the baby cannot be delivered vaginally. Now let's talk about abnormal placental attachment. In order to understand this, let's draw a picture. So normally you have the myometrial layer followed by a decidual layer of the uterus, and the chorionic villi grow into the decidual layer. And this is necessary because after delivery, what will happen is the decidual layer will separate from the myometrial layer, and that's how the placenta is delivered normally. In abnormal attachment, you still have the myometrial layer, but the decidual layer either doesn't form or it's abnormal and very thin. As a result, those chorionic villi grow into the myometrium. This creates a problem at the time of delivery because the placenta is not going to come out completely. It's going to come out in pieces. Much of it will be left behind stuck in the myometrium, and in fact, this often requires a hysterectomy because there's no other way to get all the placental material out of the body. So I've summarized these points on the slide here. The normal placenta attaches to the decidual layer, and by that I mean that the chorionic villi grow into the decidual layer, but they do not grow into the myometrium. If there is an abnormal decidua, that leads to abnormal attachment, where the placenta attaches directly to the myometrium. And there are 3 subtypes of abnormal attachment. The most common form is called placenta accreta. The other 2 types are called placenta increta and placenta percreta, and we'll talk about all of these in just a minute. As I said before, the primary problem in abnormal placental attachment is defective uterine decidualization. If the decidual layer either does not form at all or does not form normally, that's what leads to these problems. And the most important risk factor is a prior C-section. The idea here is that a C-section leaves scar tissue behind in the uterus, and that scar tissue can prevent the decidual layer from forming normally. This is especially true if a woman's had a prior C-section and now she has a placenta previa, which, as we talked about earlier, is the placenta covering the cervical os. In that situation, a prior C-section, now with a placenta previa, there is almost always abnormal uterine attachment. And other risk factors should make sense to you if you understand that C-section is a risk factor. If a woman's had prior uterine surgery or a DNC, this also can leave scar tissue behind and prevent the decidual layer from forming normally. The 3 subtypes of abnormal attachment are shown here. If you look at this picture on the right side of the screen, normal attachment is in the top left corner. You've got this decidual layer here, and that is what the placenta attaches to. In placenta accreta, which is the most common form of abnormal attachment, the placenta attaches directly to the myometrium but does not penetrate. That's shown here in the picture in the bottom left. In placenta increta, the placenta penetrates the myometrium. That's shown here in the top right. And then placenta percreta is the most dangerous type. In this case, the placenta penetrates through the myometrium, as shown in the picture here. It invades the uterine serosa, which is the outer layer of the uterus, and it can even attach to other abdominal structures like the bladder or the rectum. Now, usually this is diagnosed on routine ultrasound during the course of a woman's pregnancy, but if it's not diagnosed, what will happen is that the placenta will fail to detach after birth. So part or all of the placenta will remain behind. It often comes out in pieces, and there is massive uterine bleeding after delivery of the baby. This is a very serious and potentially life-threatening condition. It can lead to maternal hemorrhage. It can lead to shock, DIC, and ARDS. And when women are diagnosed with this ahead of time, delivery is often done in a planned setting by C-section. And after delivery, a hysterectomy is often required because otherwise you can't get all that placental tissue out and the bleeding will not stop. So that's a nice segue into the general topic of postpartum hemorrhage. After a woman delivers a baby, there is often bleeding from the uterus, so let's talk about why that happens. The most common cause is uterine atony. The uterus should contract after delivery, and this constricts the spiral arteries and prevents bleeding. If there is a lack of proper contraction, that's called atony, meaning a lack of tone. And this is often treated with the hormone oxytocin, which, as you may know, causes the uterus to contract. It's also sometimes treated with simple uterine massage, where the physician massages the uterus with his or her hands. Second most common cause is trauma, so lacerations to the uterus often occur during delivery, especially if instruments were used or surgical incisions were made, so all of these things can potentially cause bleeding after delivery of a baby. Other causes of postpartum hemorrhage are shown on this slide. In order for a woman to stop bleeding after delivery of a baby, she needs to have a normal clotting system. If she has any form of coagulopathy, she will continue to bleed. There are a couple of ways this can happen in pregnancy. First of all, blood loss at delivery may consume clotting factors, and if a woman does not have enough clotting factors left behind, she can be coagulopathic and prone to bleeding. In addition, some OB conditions can cause disseminated intravascular coagulation. So, for example, placental abruption, amniotic fluid embolism, preeclampsia, these are all associated in some cases with DIC. So if a woman develops DIC, she won't be able to clot, and then she won't be able to stop bleeding. So one of the things you do on OB rotations if a woman continues to bleed after delivery of a baby is check the PT, PTT, and platelet count to make sure she has a normal clotting system. And then finally, retained tissue can lead to postpartum hemorrhage. So the placenta should be expelled by the uterine contractions, and normally you deliver the placenta after you deliver the baby. However, if any tissue is left behind, that can lead to prolonged bleeding. And one of the things you have to consider in a woman who won't stop bleeding is that there may be some tissue left behind. I'll finish this video by discussing amniotic fluid embolism. This is a very rare but life-threatening complication of delivering a baby. This usually occurs during labor or shortly after delivery of the baby. This is caused by amniotic fluid, fetal cells, and fetal debris that get into the maternal circulation. They travel through the mother's body and cause a diffuse inflammatory reaction. This is often a fatal condition. It's one of the ways women can die at the time of delivery of a baby. In a board question, this is basically going to be a woman who has had a normal pregnancy and then gets very sick and possibly dies at the time of delivery or shortly after. Technically, there are two phases to the syndrome. In the first phase, there's respiratory distress and shock. The woman will have hypoxemia and hypotension. This is followed by a second phase called the hemorrhagic phase, where the woman has massive bleeding and DIC. The key feature here, obviously, is bleeding. The woman often goes into a coma and can potentially develop seizures, and I point out the seizures because in a board question you might think this is eclampsia because you see seizures during pregnancy, but eclampsia will usually occur on top of pre-existing preeclampsia, meaning hypertension and proteinuria. If it occurs out of the blue in a woman who has otherwise had a normal pregnancy, then they're probably talking about an amniotic fluid embolism, especially if it occurs in the setting of shock and bleeding. And that concludes our video on placental complications.